Hello, my friends. Welcome back to my channel with the new video. This is the fifth and the final short video on acute pancreatitis. And before starting my deliberation, I would again like to request you to like, share, and subscribe my channel if you have not done so far. So, in this particular section, we'll start with management of the complications. So as we have discussed about prophylactic antibiotics, which are the very clear-cut messages, in two-thirds of the patient there is no proven benefit unless there are culture positive or the radiology positive evidences, and of course you have the SIRS which will give rise to high TLC or high temperature that may not actually kind of tell us whether the patient is actively infected. And this is what I was talking about, this particular ProCap study which was published in hepatology with about 260 patients. And there was a procalcitonin driven antibiotic on day 0, 4, and 7 with a cutoff of about more than 1 nanogram per ml, where the antibiotics were started, and the usual care was given to the another group. So, what they found was the adverse effects were almost like equal, but in the antibiotic use, the patient which definitely have a better clinical outcome as compared to the usual care. So there is definitely some amount of you know impact or bearing of procalcitonin based antibiotic usage in the patients who have acute pancreatitis, and there can be a definite evidence of lesser amount of lesser incidence of infections, as you could see in antibiotic which were driven by procalcitonin as compared to the usual care. So other therapeutic interventions like insulin and plasmapheresis for triglyceridemia induced acute pancreatitis, where there is a release of the toxic free fatty acids, and plasmapheresis may remove the triglycerides. So it has a questionable role. The elephant trial, which is ongoing RCT, which investigates the concept of early elimination of triglycerides, uh, and the emphasis or benefit of plasmapheresis, and the results are yet to come. Low molecular weight heparin, of course, it will help in as a DVT prophylaxis, and this particular recent randomized single bind phase 3 control trial which emphasized the role of LMWH in AP, and this study found that LMWH was actually responsible to reduce the necrosis of pancreas, especially in the early phase of moderate and severe acute pancreatitis. So apart from the DVT, low molecular weight heparin can also have a bearing on decrease in the frequency of the necrosis in this patient. Also, there has been contemplation of pre, pro, and post biotics in the patients of pancreatitis, and there were two RCTs with synbiotics and the probiotics, but they showed no effect as compared to not use of these agents in the patients with acute pancreatitis in terms of reducing in the hospital outcomes. But yes, they definitely had a bearing or impact on reducing the length of the hospital stay in this patient. So there's definite signal of using of the pre-pro and the postbiotics in the patients with acute pancreatitis. There was also one study with Chen et al., which was in about 50 odd patients with the use of soluble dietary fiber in the form of polydextrin, and as compared to the control group, and they found that the feed intolerance was significantly lower in the patients in whom the soluble dietary fibers were used. Also, there was use of butyrate in the form of tributylene uh, as a postbiotic in the patients with acute pancreatitis, and this trial is ongoing. Uh, As far as timing and the role of ERCP and endoscopic ultrasound in gallstone pancreatitis is concerned, we have acute biliary pancreatitis without cholangitis. Obviously, the medical therapy scores over early ERCP. When AP is complicated by cholangitis, of course, early ERCP should be the choice within the first 24 hours, which may decrease the morbidity and mortality. And in the absence of cholangitis or jaundice, if a CBD stone is suspected, then MRCP or EUS should be used to screen the presence of CBD stones. So, this is in a nutshell about the ERCP and the endoscopic ultrasound. Now, something on cholecystectomy in this setting where you have a mild acute biliary pancreatitis, the early cholecystectomy, at least during the same admission. So early they talk about between within 8 weeks, and late they talk about after 3 months. So where is the when the patient has severe ABP, there is no evidence of supporting the early surgery. So there is definite some kind of signals with a feasible approach of doing a cholecystectomy in the setting of the acute biliary peritonitis or gallstone pancreatitis, acute biliary pancreatitis or gallstone pancreatitis within about 8 weeks, especially between 6 to 8 weeks. So, for the management of severe local complications, uh, remember that it's a team approach, it's a multidisciplinary approach with involvement of course, a gastroenterologist, an intensivist, the interventional radiologist, a surgeon, and the team which of course go ahead and treats these kind of patients. There is definite some signals on use of neostigmine to decrease the chances of intra-abdominal pressures. And as I said, uh, to decrease the biliary recurrence, the early cholecystectomy within 8 weeks have been found to be little benefit for these kind of patients as far as the timing of the surgery is concerned. There is also a kind of uh, uh, options in the form of immunomodulation, in the form of high volume hemofiltration, and there were meta-analysis with about 17 studies which shows that there is the standard kind of the mortality is decreased, but there is no long-term benefit. The short-term mortality can go down, but there is no kind of impact on the long-term mortality in these patients. Cytosorb, as we know, with a hemodynamic cytokine storm, which is used, and there is some signals towards there is improvement in the hemodynamics in the patients who underwent cytosorb. Thymosin alpha 1, there is no benefit, and there could be some role of immunoparalysis, especially in the late infective complications. But the things which we need to look forward is something called as multiomics, and this is a genetic kind of prediction with the four subtypes uh, with molecular endotypes, and those who have a subtype 1, then there can be a chances of persistent organ failure. So this is the futuristics of medicine in general, the genetics and genomics, and this multiomics in this particular category of patients. So if you have a subtype 1, then probably there are signals that this patient might land up in the persistent organ failure. As far as the SAP complication, as I said, step up approach is well accepted, and we are talking about the wards, that is the video assisted retroperitoneal drainage, and we will talk on that as to how these kind of modalities can be helpful for complications of severe acute pancreatitis. Now, as I said, the local complications could be in the form of acute peripancreatic fluid collections, which is typically as a early onset, diagnosed on CT or even the sonography, and it's usually a self-limiting. It may need a US guided versus percutaneous drainage. Acute pancreatic necrotic collections, or ANC, which is typically seen in the first week to 10 days. Uh, the diagnostic modality of choice would be obviously a CT scan. And of course, you give antibiotics that can penetrate the pancreas. And there could be a discussion on the role of EUS versus percutaneous drainage. As far as the pancreatic pseudocyst is concerned, it is a little late, maybe within 3 to 4 weeks. CT will diagnose, and alternative would be an MR. And you need to drain if it is symptomatic and causing pressure symptoms or complications. And of course, Vaughan or walled off necrosis, which is seen beyond 3 to 4 weeks. And if it is infected, you need to drain. If it is large, you can go ahead with VAD, that is video assisted retroperitoneal drainage. So, as far as the vascular complications are concerned, the splanchnic vein thrombosis, which is seen early within a month, you can do a CT angio and you can discuss the anticoagulation, or a local kind of interventional radiological approach. If there is a pseudoaneurysm which is seen early or late, there can be angiographic coiling for that particular complications. As far as abdominal compartment syndrome is concerned, where you need to monitor the IAP every 4 hours, the volume reducing measures in the form of diuretics or RRT, or the drainage of ascites and the pleural effusions. You need to treat the paralytic ileus with laxatives, prokinetics, and decompression. And we actually saw a role of neostigmine as well, as we discussed, and of course the multidisciplinary approach for decompressive laparotomy. As far as the recent updates are concerned, and we have discussed about cytosol, plasmapheresis, thymosin alpha. I think we have discussed about this. So it is a dynamic disease and difficult to predict. It has a bimodal temporal distribution with early mortality when the patient has SIRS or MOD. The early identification with integration of imaging technologies and the scoring systems like BISAPS and so on, as we discussed with clinical presentation, is the key. IV fluids, pain control, antibiotics, and we will discuss in the conclusion slide. So here we are actually talking about uh, a concluding slide where we would say that a fluid would be a reasonable bolus of 10 ml per kg as an initial bolus, preferably crystalloids, preferably balanced crystalloids, and then a maintenance of about 1.5 ml per kg per hour. RL, as I said, has been shown to decrease the ICU admission rate and decrease the length of the hospital stay. Of course, there is a less chance of organ failure. Nutrition, we discussed. Analgesia, we discussed. Don't forget about rectal diclofenac or rectal NSAIDs. We discussed about PCT guided antibiotic approach. And of course, when you have a late complications, don't forget, when we involve the patients with a intervention in the form of either a ward or the endoscopic resections or aspirations, or there could be a direct drainage of that particular abscess in the stomach in the form of endoscopy. So this is what I was kind of tried to deliver the message as far as acute pancreatitis is concerned. And because it is an extensive topic, for the sake of simplicity and for understanding, I divided it into 5 parts. And so again, if I may request you to like, share, and subscribe my channel. That's all for now. Let's meet next time with the next topic. Thank you.